Hello everyone, welcome to your chapter review of mental health disorders for the older adult. Your objectives for this chapter are to be able to distinguish the clinical characteristics, onset, and course of delirium and dementia. You're to integrate biological, psychological, and social theories related to delirium and dementia. And then I'd like you to be able to discuss the nursing care of a person with delirium and dementia. These two areas are going to be a primary focus for this chapter. When you think about both of these diagnoses, I want you to be looking at them in the perspective of what safety and care look like. Key concepts: cognition, memory, delirium, and dementia. I'm going to define cognition and memory for you. Cognition is the system of interrelated abilities such as perception, reasoning, judgment, intuition, and memory. All of these allow one person to be aware of oneself. Memory is a facet of cognition, so it comes under cognition, and it's retaining and recalling past experiences. When we look to define delirium and dementia, they are important different diagnoses. So when we look at delirium, delirium is considered an acute cognitive impairment, and it has lots of causes. Your book has a table on the table number 29.1 that can give you all the variety of causes for delirium. We're going to talk about a few of them, but not exhaustively. What I want you to remember for delirium is that it's an acute disorder. Dementia, which is our other cognitive change, is actually a chronic cognitive impairment. There are two types of cognitive impairments. One is a cortical dementia, and the other one is a subcortical dementia. The cortical dementia involves the globally cortex impairment, and has Alzheimer's is the most common form of the cortical dementia. The subcortical dementia involves the gray matter or the white matter within the brain. Because cortical dementia is most commonly associated with Alzheimer's, and it's also the most common form of dementia, it's the one we tend to be, it's the most common form of dementia is the one that we tend to be more concerned about. An example of a subcortical dementia is Parkinson's. I want to remind you that the cortical is the outer layer of the cerebrum. The cortical's function is higher level functioning. It helps us interpret sensory perceptions. It helps us with reasoning, emotion, learning, as well as fine motor control. When we look at the subcortical layer, that has a heavier focus on cognitive and affective experiences and the social functionings. We think of impairment to the subcortical area as being a milder impact, but that's not always the case. But just in generalities, subcortical dementia, it tends to be less invasive and less problematic. The big thing to think about when you think about delirium and dementia is to understand that you are differentiating between the two by the cause, not by the symptom pattern, because there can be some overlap with each of these, and you really want to get down to the root cause of these disorders. Delirium is explained here. It is a disturbance in consciousness and a change in the cognition developed over a short period of time. It's also usually reversible if the underlying cause is identified. It is serious, and it is a medical emergency. When we think about diagnostic criteria for delirium, what we're really looking at is an impairment of consciousness. Patients who are experiencing delirium have less awareness of the environment. They have a loss of ability to focus. They have problems in memory, orientation, and with language. This is a table from your book, and I want you to be familiar with this. I think this does a fantastic job of giving you general characteristics of what you would see with a client with this diagnosis, and then to be able to compare and contrast delirium and dementia. This is a good slide for you to know, and something that I'd like you to be able to do. I want you to be able to see a set of diagnoses or a set of symptoms with some clinical information and be able to determine whether you would suspect delirium versus dementia. we think about epidemiology and risk factors, the prevalence rate can range from 10 to 50% of older adults in an acute care setting. And I want you to take a moment and just think about what that means for you in a practice setting. Delirium patients are not commonly seen in the psychiatric setting. They are very often seen in the med-surg setting. So begin to think about how you would be screening and monitoring patients for a change in their status. And be suspicious that delirium is going on with your client. Much like your textbook explains, when you see delirium, it is often very sudden. It's going to come and go. It's not going to be a consistent set of symptoms. Their level of consciousness can be reduced. They can be disoriented. They can have visual changes, often hallucinations. They can have changes in their physical activity. They can have changes in their speech. Their speech is often incoherent, so you really cannot even understand them. Be aware that what you're looking for in delirium, because it's an acute illness, you're looking for a change from baseline. If you have a client who comes in and they're alert and oriented, their speech is clear, their memory is intact, and over their stay in the hospital or after having an intervention of some sort, if there's a change in their cognition, if there's a change in their memory and recall, you need to wonder if you're experiencing delirium. Because dementia is a chronic disorder, you're not likely to see that evolve over a short period of time during an inpatient stay. But delirium, you might. Risk factors are pre-existing cognitive impairment, severe illness, and age. Our etiology, we know that in older adults, adults who are having medication reactions, if they have an infection, fluid and electrolyte balance, metabolic disturbance, any change in their oxygenation level or ischemia, all place these patients at risk. We want to be very mindful of how small changes can impact an elderly client. We think about our clients who come into the emergency room from long-term care settings and they have a urinary tract infection. You and I could have a urinary tract infection and remain very capable of functioning at a high level without any type of cognitive impairment, and certainly being able to navigate any physical issues. An elderly client who has something as minor as a urinary tract infection can experience delirium from the infection, from a fever, from the anxiety created from being very unwell. So we want to be aware that it doesn't take a major health event to change the sensorium of our older clients. The other thing to think about is variation in brain alterations. So neuroanatomy abnormalities. If your client has had a stroke, they can be predisposed to delirium, or if they have an imbalance of key neurochemicals. And normally, if you look at the imbalance of neurochemicals, there's been some kind of injury. This is not something that is normally long-term and ongoing. Treatment and priorities. The priority is truly paying attention to life-threatening disorders. If you have seen a change from your patient's baseline, you need to do an assessment based on the baseline. How did they appear when they first entered the care setting, and how do they appear now? What has changed? What new things have been added as a treatment or environmental exposure or medication? What kinds of things have gone on? And you want to be very careful in monitoring these patients closely. We go back to those safety issues. Are they, do they need one-to-one monitoring? Do they need to be closer to the nursing station? What are their safety needs? And we want to be aware that elderly clients at a baseline have safety issues. So we need to think about clearing their path to entering the bathroom, or clearing the path around their bed so they can get up and move around, making sure that we're using patient side rails by our policy, and that we haven't put up all 4 bed rails and to keep them in bed and placing them at risk, that we've picked up IV tubing and poles and their SEDs, you know, for their DVT prevention, that we really are thinking about how could this patient at a baseline be safe, but then are they at higher risk because they're experiencing delirium, and do they need a higher level of surveillance and monitoring? From a biologic domain, these slides in this PowerPoint I apologize if they feel a little cluttered. There's a lot of little pieces of information, and I didn't want you to have to write all of these down, so I put these on the slide for you. So your assessment, your nursing diagnosis, and your interventions are all listed for you. I'm not going to read them to you. I do want you to be aware in the biologic domain, what are you looking at? The big thing for delirium is making sure you've got a really good baseline assessment, that you've covered the medications, you've covered past and current medical histories, you do a good review of systems. Your nursing diagnosis is going to be based on what you see in the presenting case of your client, and the interventions are really about safety and monitoring. We want to watch them carefully, especially if we're introducing new medications or a new combination of medications. That is a frequent cause of delirium. So we want to be aware that if we're adding a new medication and there's a change in our patient's baseline, to go back in and look at medications. And again, we go back to safety. Remember that judgment and sensorium can be impaired with clients who are experiencing delirium. And I want you to spend some time thinking about, what do you do for your elderly clients at a baseline? How do you keep them safe in the hospital environment? And then add the dynamic of having cognitive changes, of being forgetful or confused, or having an unsteady gait, on top of already being an elderly at-risk client. You know, it becomes much more complicated if they're experiencing delirium. So we want to be thinking about safety. From a psychological domain, your assessment, your nursing diagnoses, and interventions are here as well. I want to keep to remind you that there can be changes in their behavior, and they can become hyperkinetic or hypokinetic, and all that means is that they become more active or less active. What you're looking for is a change from their baseline. You want to know if someone has become, if they have had, if they've come in and their activity level is pretty standard, and all of a sudden they're pacing or they're overly excitable. They may also have some hallucinations. That would be a concerning sign for delirium. If they are hypokinetic, if they have less energy, you're going to see lethargy, you're going to see somnolence, you're going to see apathy, kind of a withdrawn affect. So you want to be aware, you know, what's their normal activity level, what's their normal disposition, and is there a change off of baseline? Environmental controls, it goes back to making sure that you've got that you're doing what you can to lower the stress for these clients. If they are already experiencing some confusion, if they're already experiencing those early signs of delirium, you want to put them in an environment that is safety focused, that has decreased stimuli, that has as much of a quiet environment as possible. You want frequent verbal orientation. You want to make sure that you're going into the client's room frequently and reminding them where they are, who you are, assessing what their needs are, being available. And the other thing to remember, if you've got someone who's probably has been stable from a psychological baseline, they're experiencing delirium, they are likely aware that something is off. So their anxiety and their fear is probably elevated. So by being present, by reorienting them, you're offering a comfort measure. The other thing to make sure, and this is just one of the basic things we should do for all of our clients, make sure that their adaptive devices are available. If they wear hearing aids, make sure their hearing aids are in. Make sure that if they have glasses, that their glasses are available. You want to make sure that you do everything you can to support clarity for them so that they're less anxious and they're less fearful. Your social aspect for delirium is pretty straightforward. If you have a client who's come in experiencing delirium, you want to get a good background of where they live, what their living circumstances are, and gather information about the support system. If you are in the hospital environment, you want to make sure that you're talking to the family that's visiting, because they're going to be alarmed if they have a family member who's been pretty with it and alert and oriented and pretty active, and there's a change and they're experiencing delirium. Active, involved family members can be some of the first people to notice these changes, because they know their loved one well. So be attentive to what the family is reporting and what concerns they're expressing, and don't dismiss it out of hand. You want to go back to your assessment and make sure that you're looking for as many data cues as possible, so that if the family is correct and there has been a change off of baseline, that you're monitoring that, and you're monitoring it early before it becomes a life-threatening issue, and you have a further decompensation. So that's the focus in delirium. Remember that this is an acute disorder. It's often brought on by complicated medications or medical changes. this is something that needs to be treated as a medical emergency, and it needs to be treated pretty quickly. So if we're agreed that delirium is acute, then let's talk about what chronic changes look like, and we're specifically going to talk about Alzheimer's disease. It's a degenerative progressive neuropsychiatric disorder. I will tell you that it is not common to have Alzheimer clients in a psychiatric setting. Most often, advanced Alzheimer clients who are living with Alzheimer's at an advanced stage are in a memory care unit or a secured environment that provides long-term care. A psychiatric setting can be extremely distressing unless it's specifically for clients living with Alzheimer's. So we want to be very responsive. If for some reason we have a client who has come in and is presenting with what they feel like is psychosis, and they begin to realize it really isn't psychosis at all, it's not delirium, that it really is Alzheimer's, then we need to get them properly dispositioned. We know that early onset is considered something that happens between 65 and younger. It has a rapid progression. It's also not very common. And the outcome of someone with early Alzheimer's is pretty poor. The prognosis is poor. Late onset, older than 65, is more common, and it has a slower progression. We look at the multiple cognitive defects. We have aphasia, apraxia, agnosia, and the disturbance of intellectual functioning. Want to kind of recap what I think your slide gives you some of the multiple cognitive defects, but to remember that in the bucket of Alzheimer's, you're seeing cognitive impairment, emotional and behavioral changes, physical and functional decline as well, and then unfortunately, kind of the end result is an untimely death. Alzheimer's can, especially in the rapid progression, cause an early death. So this is something that we want to begin to treat the symptoms as aggressively as possible. I just want to back up for a second and when we talk about the impairment of executive function, the idea behind executive functioning is the individual's ability to use reasonable judgment, sound reasoning, and the ability to problem solve or make decisions. The executive function is significantly impaired in advanced Alzheimer's. They have an extreme difficulty in reasoning and using rational judgment. They have a hard time problem solving or abstract thinking, and that's normally one of the kind of red flags for the healthcare community that thinks, okay, this is more than just getting older and just having a harder time remembering things. This really is a clinical condition. So I want you to be familiar with what executive functioning looks like, and that's something we really need to watch for, but it most often occurs in the later stages of Alzheimer's. Epidemiology is listed here for your review. The etiology, we do know that there's a familial link, and the familial link is especially more common in the early onset Alzheimer's. You've got plaques. I'm going to let you read all of those. One of the things that become most concerning for families living with Alzheimer's is the memory changes are the most dramatic and the most consistent cognitive impairment with dementia. So the thing that makes that person who they are, their memories, the things that they shared with other people, is the thing that is the most dramatic. It's the thing that the families, it's almost always the first thing that family notice is starting to slip away, and that can be very distressing for family members who are realizing that their loved one is experiencing some Alzheimer's. And one of the things that I think our memory care units, the units in long-term care facilities that are specific to caring for Alzheimer's clients, is the fact that they have to be cognizant that there's significant memory impairment and that short and long-term memory. So we want to be aware that we need special support for those concerns. This is also an interdisciplinary treatment approach. You want as many people available to help the client in whatever their specific needs are. You need to manage their cognitive symptoms. You need to manage their cognitive decline. You've got to handle any type of psychosis. Are there hallucinations? Is there agitation? And the other piece of this is you've got to look at caregivers. This is so stressful, and it may be the caregivers are their children. It could be a spouse. Really being aware that the person that they've known their whole lives is suddenly a very different person, and very often doesn't even remember them or have clear memory. And again, we come back to safety issues. We have to be aware of that because there is memory impairment, and their executive functioning is impaired, their judgment's impaired. So these folks have real risk for safety issues. So we want to do what we can to help support their memory. Let's talk about these in the domains. Biologic, these are here for you with your assessment, diagnosis, and intervention. The important thing with the biologic domain is, much like delirium, you've got to know their baseline. Because as the disease of Alzheimer's progresses, you want to have a better sense of how quickly it's progressing and where the functional areas are most impacted. So without a good baseline, you're going to have a hard time knowing where you are on the progression of the illness. Your nursing diagnoses are going to be based on what you see clinically and what's presenting. You want to maintain as much autonomy and self-efficacy in managing their self-care, their ability to manage their own health, just the basics of using the bathroom independently, managing nutrition and diet, and making them as independent for as long as possible, especially in the basics of care. We think about the activities of daily living, specifically the ones that involve self-care from a physical standpoint. Let's talk a few minutes about medications. Medications are coming leaps and bounds in how we're helping provide care for Alzheimer's clients. The two main buckets that are specifically targeting the etiology of Alzheimer's is the acetylcholinesterase inhibitors, and there are 3, and I've listed them for you. The idea with the acetylcholinesterase inhibitors is that they prevent the breakdown of acetylcholine. And when it prevents the breakdown of acetylcholine, what that does is it makes it more available. And because it's more available in the brain, the target cells that are specific to cognition have an increased availability of the acetylcholine, and that helps them with increased firing. So it creates an excitable response to the receptors specific to acetylcholine. So I want you to remember that that's the neurotransmitter they're working on, and that with these medications, the target is to bump it up, to make it more available, to help stimulate the brain and brain activity, to help with clarity and memory and thinking. The NMDA and antagonists, those 2 are listed. They target glutamate receptor sites. So with Alzheimer's, glutamate hyperactivity causes cell death. So we know if glutamate is overly involved, that there's death in cellular tissue. So if the NDMA medications block it, it's a protection to the brain cells. It prevents the glutamate from getting to the brain cells and causing more cellular death. So whereas the acetylcholinesterase is bumping up acetylcholine, the NMDA is limiting or blocking glutamate. So I want you to be familiar with those classes and the examples that are provided and understand how they work in helping protect or enhance cognition. Antipsychotics are used. They're going to be second generation, most often, antipsychotics for clients, and most of the time it is they're targeting the symptoms that are being seen in the presenting client with Alzheimer's. If they have social withdrawal, if they have kind of those negative side effects, there's negative symptoms from schizophrenia, difficult with speech, difficult connecting, then those second generations are going to help. Every once in a while, you can have some irritability and some aggression that is from impulsivity and from some brain changes. They're going to try a second generation antipsychotic to address that as well. Seroquel or risperidol. Seroquel is the one I've seen more often. You don't have to remember like specific drugs. What I want you to know is that the antipsychotics, if they're used with Alzheimer's, it's because of the negative symptoms, and every once in a while some mild aggression or agitation. Agitation is probably a better word, because if they're aggressive, they're going to be doing some other things. Antidepressants and mood stabilizers. Again, if you have a client who's really withdrawn, and the withdrawn has more of a depression element versus a social element, then you're going to try antidepressants, anti-anxiolytics. Again, you're going to use that if you see it. And other medications, these clients tend to be at risk for the anticholinergic effects of medication, so I want you to be aware of that, what that looks like. The big thing for this is understanding the acetylcholinesterase inhibitors and the NMDA antagonists. Those are the big heavy hitters from this diagnostic area. The others are as they come up, and they're treating presenting symptoms that are unique to that individual. It's very rare where you're going to say you're going to use this one drug for everybody, aside from the first two categories. And I do want you to be able to differentiate between those. The psychological domain, again, your assessment, nursing diagnosis, and interventions are placed here. The important thing from a psychological domain, I think, comes under knowing the client well and having a relationship with them. A long-term care, long-term therapeutic relationship is very supportive for clients who are experiencing changes in their memory. Very often these clients, like early delirium, these clients know that things have changed. And at first it can be, oh, I'm just getting older, and I don't think as well. And they are likely to be alarmed by this as well. So having a long-term relationship, a consistent relationship with someone is very important. I want to give you some definitions. There are a few other things that I want you to be aware of. Visuospatial impairment is defined by tasks that require sensory and motor coordination, and it can be impaired with Alzheimer's. So the ability to write, printing words, or to draw. So visuospatial impairment is something that when you're going to do an assessment, your list under assessment has visual impairment. They're not talking about visual acuity. They're talking about the visuospatial impairment, and that's the ability to use sensory and motor coordination to complete a task. A good screening of this is having a client use a clock or draw the picture of a clock. Ask them, can you draw the face of a clock with the hands of the clock pointing to 7 o'clock? They will not be able to do that. It won't even look close to a clock, and that's because of visuospatial impairments. The other thing to add in that list under behavioral responses is a catastrophic reaction. A catastrophic reaction is when your client overreacts or has anxiety over everyday situations. And I'm not talking about, a little bit of irritability. I'm talking about a client who is in the kitchen and they drop a glass in the sink and it breaks and they become hysterical. And so their emotional response is kind of over the top. It's catastrophic. That exaggerated emotional response to minor things is also something that we see that can be very impairing for clients living with Alzheimer's. A behavioral change that can be seen with these clients is hypervocalization. Hypervocalization is the repeated verbal behavior repeated verbal behaviors that are highly disruptive. Very often they can yell, and it can be completely nonsensical, where they just vocalize things that may not even have meaning. And it's very, very loud, and it's very disruptive, and that can make clients around the person with hypervocalization very uncomfortable, and it can be very embarrassing for the family. The other thing to tuck in under behavioral responses is, remember, we're dealing with a client population that has impaired executive function. So the impairment of using good judgment and reasoning is a real issue. One of the issues that these clients have can also be disinhibition, and that they can be hypersexual. So when we think about disinhibition, these are clients who are perfectly comfortable taking off all their clothes and walking through a community area, and not understanding that that's not socially appropriate. This can be someone that becomes very promiscuous in an advanced age and becomes very inappropriate in a way that is very much outside their character. And that again can be very distressing for family. And all of that goes back to the impaired executive function, their ability to critically reason and think through the consequences of, all right, I've never, you've seen this person and they've never behaved this way, and all of a sudden it's very outlandish. You have to go back and kind of think, okay, what are we dealing with, and understanding that impaired executive function could be a real issue for these folks. Again, the takeaway intervention for this is really understanding and having a good relationship with the patient in a long-term therapeutic relationship. And whether that's an older adult clinic that they go to every week, whether it's an adult daycare environment where you have the consistent provider so that they can really monitor the progression, and that there's a consistent caring relationship is really important. It's also important for the family. If we there's some specific areas in the psychological domain, and I put these up here on the slide under mood, psychosis, and behavioral, and I'm not going to read these to you because these are just examples of things that you're going to see. So when we think about interventions, what are we going to do for these clients? You're going to manage their moods, you're going to monitor for psychosis, and you're going to treat it as it occurs. And the behavioral problems, you're going to do what is necessary to offer support for behavioral changes. I want to remind you guys that reorienting a client who has Alzheimer's, especially moderate to advanced Alzheimer's, is pretty challenging. So what you're going to do is you're going to use validation therapy, and that's a method that is used for communicating with a patient that has Alzheimer's disorder. The nurse does not try to reorient the person, but rather respects the individual's sense of reality. So this is not an elderly person who, you walk up to them and they say, "Oh, Alice, I've known you my whole life. It's so good to see you." And you're not Alice. This patient authentically believes that you're Alice, and reorienting her and saying, "No, my name is Tracy. I'm your nurse. I was your nurse this morning," is not going to have clinical efficacy because they're not going to recall that. A more therapeutic response for you is to be able to say, "I know you think I'm Alice. Tell me more about her." Because that person for some reason has meaning, and there's something about you that's reminding you about that, that's reminding the patient about that person. Trying to reorient them can actually cause more distress, and it doesn't have a functional purpose because they're not going to retain the reorientation. So you certainly don't want to feed into it, but you also don't want to challenge it. So you want to be very gentle in how you handle that. And by the validation therapy of just accepting that is the person's perspective, that's more therapeutic and less disruptive for that client. And I know that feels counterintuitive, especially because we're hardwired as nurses as, we want our client alert oriented, ×4. And if they're not, boy, we're going to talk them to death until they really get it. These clients just remember the etiology. The underlying cause is an organic brain change. So you reorienting can create an emotional response that could be very distressing, and they are not likely to remember it. So we want to use that validation therapy whenever it's appropriate. Let's talk a little bit about social domains. I think this is a really good list for you to look at. The support system, if you wanted to say, this is kind of the bullseye for how you handle the social domain, folks, it's the care and the support of the primary caregiver, because this person is disappearing in front of them, and is extremely distressing as a family member to see the person that you have loved, your whole life, or has taken care of you your whole life, slipping away. And it is genuinely not something that we can have significant impact on stopping. So for family members, it becomes it is what it is, but they still miss their loved one. So there's a real grief process going on with these families. The individual can have some significant social issues as far as connecting with the social setting. So we want to be aware of kind of what their thing is and help them navigate any social issues they're having. And you also want to make sure that clients who are dealing with Alzheimer's have a social network, that even if they are not oriented, and even if they have very impaired memory, that we are connecting them with current relationships, that we do the adult daycare, that we do memory care units, that we take them to the library. We give them every opportunity to connect in a meaningful way to the people around them, because that is still so very important. And even if they don't remember that they were at the library tomorrow, in that moment, it's still very healthy, and it's still living a regular life. And to create a sense of normalcy and autonomy in the moment is a very therapeutic role for the care providers. And then being sure that you're offering as much support to that social fabric, to that social network that's providing care, and making sure that they have what they need. Our last slide is looking at the other dementias. I want you to have a general idea. This slide is perfectly fine for looking at just being familiar with other neurocognitive disorders. You don't have to do that much more. I think this slide, I want you to see Parkinson's and Huntington's and frontotemporal neurocognitive. I want you to see all those words and have a general idea that they fit in this bucket. Okay, folks, that's it. If you have questions or concerns, please touch base and let me know how I can help with clarity. Otherwise, I will see you soon.